All right, welcome everyone. My name is Lauren Tobias, and I'm going to be moderating today's sleep seminar. I have a few quick announcements before I introduce our speakers for today. First, in order to receive CME credit for attendance, please see the chat room for instructions. You can text the unique ID for this conference anytime until 3:15. If you are not already registered with Yale CME, you will need to do that first. If you have any questions during the presentation, I encourage you to make use of the chat room throughout the hour. We also will have some time at the end for folks to unmute themselves and ask any questions that they have. And finally, please feel free to share the announcements for this weekly lecture series to anyone else who you think might be interested. They can reach out to Debbie Lovejoy to be added to the email list. So now I am delighted to introduce Doctors Ivan Kimuli and Susan Adakun. They are two physician observers who we've had the pleasure of hosting in the section of Pulmonary and Critical Care Sleep Medicine for the past 5 months. And I know I speak for the entire PCCSM faculty when I say that it really has been a true delight to have them in our clinical settings and an honor to get to know them as individuals. Today, they're going to be sharing their stories, providing us with a glimpse into the practice of medicine in Uganda, describing the current state of pulmonary and sleep medicine there, and discussing how they hope to enhance care for patients once they return home to Uganda in just over a month. First, I'm just going to start off with a few words about each of them. JP, I see you're here. Did you want to introduce Susan, or would you like me to go ahead? I'm happy to introduce both, as was my plan. I'll assume that's what the hand wave means.
Oh, sorry, I was just the audio.
Oh,
Well, I'm happy to introduce Susan.
all right. Go. You said you're happy to. You can go on.
Oh, well, Susan Adakun is an internal medicine physician that works in Uganda in the pulmonary hospital. I don't have the PowerPoint slides with Susan bio available to me right now, but from a first-hand perspective, I can say it has been a pleasure to have her join our ILD group. She has been interested and devoted to increasing her knowledge in interstitial lung diseases. And she has told me firsthand about the limited resources and availability of providers to take care of patients with ILD in Uganda. Her hope eventually is to use this knowledge to grow and the first ILD program in her country, which will fully plan to hopefully continue to support her in her endeavor. And yeah, it's been a pleasure to have Susan. I can't believe the time has flown by so fast. We're almost a month away from being done.
Thank you. Thanks, JP. And just to round that out a little bit about Susan's background. So, Dr. Susan Adakun is a physician at Mulago National Referral Hospital, which is the primary teaching hospital for Makerere Medical School in Kampala, Uganda. She's worked there since 2015, and she specializes in clinical care, teaching, and research in the pulmonary division within internal medicine. She received her medical degree from Makerere Medical School in 2006, and then Barara University of Science Technology in 2014. She completed the ATS Global Scholars Program in 2015 and 2016. And as Dr. Higuera Sivia had said, that her primary goal here at Yale has been to learn more about interstitial lung disease, but she's also developed an interest in sleep medicine while here. So I'll introduce Dr. Ivan Kimuli. He is also an internist from Mulago Hospital with clinical care, research, and academic teaching experience. He graduated with an MPH from the University of California, Berkeley, and he holds a medical degree in internal medicine from Makerere as well. He is a lecturer at Makerere University and the head of clinical services there at their Lung Institute, where he oversees clinical operations and patient care, including management of patients with sleep disorders and pulmonary conditions. His research has been focused on respiratory infections, HIV, and tuberculosis, and he's had an active role in COVID-19 research in Uganda. So without further ado, please join me in giving a warm welcome to both Doctors Kimuli and Adakun for their talk this afternoon, which is entitled Practicing Sleep and Pulmonary Medicine in Uganda, Challenges and Opportunities. And I will turn it over to you, Ivan.
Right. Thank you very much, Dr. Tobias and Guero, for those wonderful introductions for both of us. So good afternoon, colleagues. I and Susan are delighted to be with you this afternoon to try and share with you what our experience has been at Yale, and also venture into the practice of sleep and pulmonary medicine in Uganda. My name is Ivan Kimuli. You can call me Kimuli, but Susan will be taking us in the later half of the presentation, but I'll give her a slide where she will introduce herself after I have introduced myself. Allow me to, I hope we have no disclosures to make on my part and on Susan's part, but she will also say it for herself. So the objectives for this session are basically to understand the structure and organization of the healthcare system in Uganda. I hope the slides are moving. Want to be sure?
I don't think so. Are you sharing it, Ivan? I'm just seeing the.
Oh, you're not seeing any slides?
We're seeing the PowerPoint, but with a conclusion slide up.
Okay, I think I'll stop
I
here.
think you need to put it back in presentation mode.
Okay, we'll do this. So can you see the slides now?
That's perfect. Thank you.
And are they moving?
Yes, perfect.
Great. So these are our session objectives for today: to understand the structure and organization of the healthcare system in Uganda, and learn a bit about the diagnostic and treatment services for sleep and pulmonary diseases at Mulago, which is the teaching hospital for Makerere University. We also want you to hear about our personal experience at Yale, and we'll share our key lessons and best practices that we have observed at Yale. So, like introduced earlier, my name is Ivan, lecturer and physician at the Makerere University College of Health Sciences. And I got interested in sleep when I got the first contact with one of our collaborators at Makerere in 2018, when they came in to perform some studies in respiratory function testing. And for some reason, they came along with some sleep devices, and they felt like for a comprehensive pulmonary service, we needed to have sleep services as well. So they came in with a technician, a sleep tech, who gave us a quick 1 week's or a quick 1 week's course on, I call it a crash course on interpreting sleep studies, and that's all we got. So we received our maiden devices, which were Alice PDX devices. And I started reading some of these tests or studies, and I got excited and interested in sleep medicine. One would argue, why worry about sleep medicine in a setting like Uganda, which has more of other conditions? But we know that the prevalence of non-communicable diseases is growing. And indeed, the burden of sleep disorders is unknown, but considering the risk factors for sleep disorders are prevalent in our country, we believe that it is essential to prepare ourselves. Let me ask Susan to introduce herself.
Yes, thank you all. I was introduced earlier. So why did I choose ILD track? I chose ILD track because interstitial lung diseases are difficult to diagnose. They require extensive knowledge in radiology, because you must be able to interpret the CT scans, rheumatology, because of the involvement of connective tissue diseases, occupational health, because of the exposures, genetics, and you should be able to do lung function testing, and then bronchoscopy for diagnosis. So extensive knowledge in all those aspects. And then also because tuberculosis is very prevalent in my country, and many ILD patients are misdiagnosed as tuberculosis, and therefore they will suffer when they are undiagnosed. And then those who get TB treatments will suffer TB adverse drug reactions. So this explains why I chose the ILD track. Over to Kimuli.
Okay, so a little bit about the Pearl of Africa. So Uganda was branded the Pearl of Africa quite a number of years ago in Sir Winston Churchill's book. And if you look around it, it's because of the biodiversity that the country has. Right now, it has approximately 48.5 million people. The capital is Kampala, and the official language is English. We have Swahili coming in, which is an East African language. Our GDP per capita is about 970 US dollars, with only 7% of this spent on healthcare. Our life expectancy is 64 for males and 68 for females. I invite all of us to Uganda to see the abundant wildlife that we have, the chimpanzees, the rare birds, and it is actually home to the River Nile. River Nile is the longest river in the world. So the lake that is the source is in Uganda. So what does the health structure, the healthcare system look like in Uganda? Uganda has a healthcare system that starts from the grassroots and is overseen by the Ministry of Health at the top. So the lowest health unit is referred to as a village health team, which is usually composed of 1 or 2 persons that are coming from the village. These are very lay people, but they connect the community to the first level health facility. So we do have the household communities being connected to the second level, which is health center 2s, as you may see from the top coming down. And then we go down to health center 3, then we go down to health center 4, or which is primarily a referral unit at the district level. We end up having district hospitals, which are finally served or referred to regional referral hospitals. At the moment, we have 17 regional referral hospitals in Uganda, and these regional referrals are mandated to refer complex cases to the national referral hospitals. We have 3 national referral hospitals in the country. A little bit more about Mulago Hospital. On your right is the entrance to Mulago National Specialized Hospital, which was founded in 1913 with a 1,600 bed capacity. It's the largest hospital in the country, serving over 50 million people. And on your left is the Ivory Tower, which is a symbolic building that you would call the Harkness Tower of Makerere. Founded in 1922, the largest and oldest institution of higher learning in East and Central Africa, graduating over 600 people, made health professionals in a year. So where are the beginnings of sleep medicine in Uganda? And I hinted a bit during the introduction. We have a collaboration between Makerere University and many other institutions, Yale being one of the oldest collaborations that we have had at Makerere. But this particular one is a collaboration that came through Makerere University Lung Institute, which is abbreviated in as MLI, and Plymouth University, which is also hosting Plymouth Hospital in UK. So this collaboration, like I mentioned, donated to us 2 devices at the time in 2018. And these 2 devices we started using these to perform sleep studies. Of course, over 2 years without having a lot of experience in taking care of these devices, and considering they were refurbished, we got technical issues down the road after performing about 50 tests. In 2022, one of the people that has actually been to Yale, currently at University of Miami, has a collaboration that is undertaking COPD research in rural areas and patients in a community that uses a lot of fossil fuels. And he's interested in understanding obstructive sleep apnea in patients that have COPD. So along that research track, he was happy to donate to us two devices, the apnea links and two NOx One machines. These have been used in the clinic, and close to 30 patients have performed these tests. Interestingly, you may see a picture of one of the patients on the right who has the NOx One connected. But because of the complexity of using the NOx One as a home device, many a time we have actually deployed the apnea link as opposed to the NOx One. 2024, tracking very fast, we have the MUU collaboration bringing Susan and Ivan to Yale. What do Susan and Ivan come to do at Yale? We want to become the first trained specialists. I am interested in sleep medicine, and I hope that this exposure that we have had at Yale is going to create a huge platform for us to upgrade the level of care we have in sleep medicine. So what treatment options do we have in Uganda? And naturally, as you would imagine, we don't have a lot of capacity, but we still move with what has been studied to provide a difference. So lifestyle modification, weight loss, positional therapy, counseling patients about avoidance of alcohol, and smoking cessation. A handful of patients that can afford to get CPAPs from out of Uganda, say from India, from China, and some that have relatives in the US, have been able to access CPAP machines. But as you can imagine, how are these monitored? How the patients are monitored in terms of response to therapy, and whether the pressures are fine, whether there are any leaks. These are challenges for those 10 patients, and many times we don't get to see them. Sleep hygiene, and of course, with other multidisciplinary team members, managing comorbidities that align themselves in the position of sleep disorders, including psychiatric illnesses. So the current challenges that we find in Uganda are vast, but primarily there is a lack of awareness of sleep disorders. This cuts across the general public as well as the healthcare providers. The healthcare providers have not even, some of them have not even heard about just a simple element of sleep apnea. So they do not diagnose, or they not look out for it. And so patients are not referred for care. We have limited diagnostic capacity. We have high costs of care for drugs that are used in management of many conditions, including the ones that I suspect could be used for sleep disorders. And we also have limited access to CPAP devices because of the costs. So we don't have any trained sleep specialists in the country. And as you will learn later, we also have very few trained pulmonologists, probably less than 10 in the country. Neurophysicians and neuropsychiatrists who usually see patients that have sleep disorders are also very few in the country. So clearly you see that there's a gap in terms of probably the burden that we don't know yet, but we suspect based on the prevalent risk factors and the healthcare team that is meant to take care of these patients. The poor health system where most of the patients pay out of pocket. And interestingly, in the whole of Africa, there is no institution that offers a certified program for sleep training. What about research? In general, there is limited data that comes from Africa. In this review article by Komolafe, we actually appreciate that between 2010 and 2020, there were very few articles that came out of Africa in a span of 10 years. Interestingly, if you look out for the map of Uganda, the place of Uganda there is 0. But during my literature review, I actually found a publication by one of my colleagues at Makerere, which was talking about the prevalence and factors associated with sleep disorders. And this was done in 2018. I don't know how it got to be left out, maybe because it was pediatric, but I don't think, I'm trying to explain myself. But at least we have 50% of what is in Zambia. I think Zambia has 2, so 1 is 50% of that. However, coming to Yale, we have picked up on research skills related to obstructive sleep apnea. And right now we have an ongoing narrative review writing that is being supported by Dr. Andre Zinchek and Yvonne Chu. So I'll give a little bit of highlight on how our general experience at Yale. Arriving at Yale has been a very memorable experience. We were attached to very, very nice mentors, Dr. Lauren Tobias and Dr. JP Higuero. And these mentors are the ones that actually carried us on their shoulders, liaising with faculty to draw schedules. The observership has been intensive and comprehensive, that is designed to literally see everything, but of course focus more in what the area of interest is. Like mentioned earlier, my main area of interest was sleep, and I've spent most of my time in the sleep clinic and attending the other specialized sleep clinics that are related to obstructive sleep apnea. And we have also been able to rotate in the other areas of pulmonary, ILD, radiology, and we have also been able to have an inpatient observership in the MICU. We have had quite some interesting moments in the MICU, really looking at how patients are managed. We have also done a lot of lab observations. We have been to the pulmonary function testing labs, and we've also been able to interact with the interventional pulmonary team as they're conducting invasive procedures, including bronchoscopy and thoracoscopies and others. When the fellows came, we were able to attend summer lectures with them, which was a very good experience because we had missed it for the time that we were home. So this is an observership that started many years ago, but it was blocked by COVID. So most of the lectures we were attending remotely from Uganda, but now we were having them physically with the fellows. The bootcamp lectures, sleep seminars, we have noticed that there's a lot of punctuality at Yale. Work starts at 8 and people are there. The patients are there. The patients come on time. When they're booked to come at 8:30, they should be there at 8:30. Of course, once in a while they default and come in maybe later, or they actually don't show up, but it's a good thing and we hope that we can emulate this. Working with attendings, fellows, peers has been invaluable. We have attended, we have been able to see over 98% of the patients that we have been given access to, because the attending always has been asking the patient whether they are fine with an observer being in as they're having the consultation. So this has made the patients feel safe, and indeed, when the patient is uncomfortable, they would let us know, and this was really done in a professional manner. So we would observe the attending while they're doing the consultation. We would ask questions. Some patients were willing to have us ask them questions directly. And this was a good thing, really talking to the patients and also sharing some of their experiences with us. When the attending leaves and the patient is out, or when the patient leaves, we also have further discussions with the attending to really make sure that we have appreciated the case just before us. So how has the sleep journey been? The sleep journey has been comprehensive. We have observed in-lab studies with the technicians, the PSGs, the MSLTs, We have read studies with the fellows and the attendings, and we have also had an opportunity to go to some special populations, including the pediatric sleep clinics. We've seen the RLS clinic, as well as the hypoglossal nerve stimulation services under the Inspire clinic. Sleep meetings in Houston, the sleep meeting in Houston, we were fortunate to attend that, and we made a few contacts with the people that matter or that are voices in sleep medicine. And we have also started embarking on a sleep research profile. What did we learn to be specific? We learned about the spectrum of sleep disorders, scoring sleep studies. We were exposed to the treatment protocols for SDB and the drugs, the multiple drugs that are used in sleep medicine. We got an exposure to CBTI, and we have also now gained research skills specifically related to sleep. What we hope to see when we go back to Uganda, we have been managing sleep patients with what has been evidence-based, though not at a high level. So we'll continue with the treatment strategies that have worked. And then we shall embark on training and educating the community, the healthcare worker community, but also the public. The plan is to really go back and establish a platform that we are going to use to educate and ensure that everybody is aware and sensitized about the burden and the catastrophes that await any person that has sleep disordered breathing. We plan to increase diagnostic capacity through talking to the Ministry of Health, but also ensuring that we get low-cost devices from areas where devices may be obtained relatively cheaper than maybe in the US. But if we could also get access to refurbished equipment from the US, that is also a welcome idea. We plan to bring dentists on board in order to work with them in developing appliances for use for patients with OSA, and the biomedical engineers who would be very instrumental in ensuring that the CPAP devices operate for the good of the patients. We plan to expand research beyond what is current. We have tools that we have used for a very long time in Africa, in Uganda, and some of them have actually not been validated in the African population. So these are low-hanging fruits. For example, the questionnaires that we use to stage, or rather to diagnose, to risk stratify. So these are questionnaires that we probably need to validate, and others. And we have established memberships with sleep societies. We were lucky to be introduced to the African Sleep Society that is in the budding. We have become members of the American Association of Sleep Medicine, but we also hope to include ourselves in more sleep societies that are going to enrich the practice of sleep medicine in Uganda. At this point in time, I want to invite Susan to pick up the presentation so that we can take on questions afterwards. Susan.
Okay, thank you, Ivan. So Susan here again. I want to give you an experience of pulmonary clinical care in Mulago Hospital. So in Mulago, pulmonary medicine is a standalone. It's not combined with sleep medicine and critical care as one department. We do a weekly chest clinic and inpatient care. And the division is run by physicians, both from Mulago Hospital and Makerere University. On a typical ward round, it's crowded. It includes the physician, 10 medical students, 4 postgraduates, 1 or 2 nurses, but there are no pharmacists on the rounds because there are too few. In Uganda, in Mulago, the attendings, they always know the cost of the diagnostics and treatment, and they will discuss them with the patients. If the patient is able to discuss, they will be able to explain what they can afford. If the patients cannot communicate, we use what we call the blanket sign for bedside assessment of affordability. As you can see, the blanket on the upper side and is not like the one on the lower side. For a patient, for example, who needed imaging and your and you need a CT scan, the patient on the lower side would be able to afford a CT scan compared to the patient whose bed is on the upper side, because they may not be able to afford, and therefore you will do an X-ray for such a patient. So it's called a blanket sign, and we use it during the ward rounds to quickly make decisions about the patient's care. Waivers are available for some diagnostic tests. However, they are limited. The attending must show that the patient is unable to afford, then they can get a waiver. We don't have national health insurance. However, there is insurance on private basis, but it's also limited due to cost. So social experience here, we arrived in April at Yale. We were received by the Office of the Global Health, who settled us in. We live at our house at downtown Elm City, and it's near everything, and such a nice homely setup. We were welcomed by the cold winds and ice flakes on the street. It was really cold, and then a COVID jab. We are grateful for the Yale shuttle system because we were able to run from our house into the Yale shuttle to go to the hospital. We got lost daily for the first 2 weeks because the Yale New Haven Hospital is so huge and all the blocks are so alike. It was really a difficult thing to get along. And then the trouble of the accents. I complained to my colleague that nobody gets my accent when I speak. And then he said to me, Ivan said to me, well, where there is O, put an A. So if it is hot, say hot. And once I learned that, the colleagues were able to understand me better and my communication improved. So the picture above is of the Ugandan medical students from Akello who visited. We had a chance to take them to the Hammersonet beach and had a good time there. And then Tracy and Jeremy of the Office of the Global Health invited Ivan and I to their home on 4th of July. So we had American dinner. It was really nice, and we felt welcome into American family, and we appreciate that a lot. So next steps for ILD in Uganda, we want to improve ILD diagnosis in Uganda by increasing awareness. We want the healthcare workers to know about ILD, how to identify it and refer appropriately. We want to be able to get hand-on skills in bronchoscopy, because it's very important to do bronchoscopy to diagnose ILD. Also, we want to enhance CT scan interpretation, because it is key in explaining the patterns for ILD. And we want to be able to form multidisciplinary panel to discuss radiology case conferencing, so that we are able to make diagnosis using CT scan in conjunction with the radiology team. In terms of treatment, yes, we shall continue to remove exposures, although this is normally late. By the time the patients present, it's already late. But if we can identify the exposures, then we shall avoid continued exposure then. In terms of treatment of connective tissue diseases and other forms of ILD that are inflammatory, we've been using a lot of prednisolone. But then this is being overused. When you want to prescribe the prednisone for a patient, they don't come back. They just keep buying it off the counter. And therefore, the side effects of prednisone have been unbecoming, which so we should be able to prescribe other immunosuppression drugs other than prednisone. In terms of idiopathic pulmonary fibrosis, although antifibrotic therapy does not cure the disease, it can prevent further progression, but this is limited in our setting because of the expense. So this is a pictorial of our experience. So you can see there Bramley Kyle, the robotic bronchoscopy specialist. It was very amazing to experience that. We have Rushka Cabral, the first-year fellow, who taught me how to use a point-of-care ultrasound scan. We have Chap, Dr. Geoffrey Chap, with asthma specialist, and then the sleep fellows that we interacted with during the sleep rotation. And those who are not in the picture, we just didn't have the photos, but we appreciate all the attendings, all the physician assistants, and all the fellows who helped us achieve our dream. The challenges that we got while at Yale, the biggest challenge was the public transport to Winchester Clinic at North Haven. The buses are so unreliable. So you wait for the bus says it's coming and it doesn't come on time. However, once you get on it, you smile because you know you're going to get where you're going to go. There was no access to Epic and no access to patients. This we expected because we came knowing. Yeah, but it was it would have been a better experience if we had access to this. So the key findings is the learning points are: 1, punctuality. The attendings, the patients, they keep time. And work starts at 8 and everything is set, which is a good practice. The booking system is good because the attendings know whom to expect when, and they plan and read around the patient and even consult their colleagues, for example, in radiology to read the CT scan ahead of the patient. But it can take up to 4 to 6 months for the patients to be seen. So it is a long waiting time. Insurance at Yale is very pivotal in diagnostic and treatment options. So many a time the attendings must first wait to see what the insurance is going to say, whether to approve a treatment or not accordingly. The Yale pulmonary system is highly specialized, and if a patient has other ailments, they'll be referred to primary care physician. And this is unlike in Uganda, where when you see a patient, you will have to prescribe medication for all the other ailments. For example, if they have ILD and they have back pain, you treat the back. They have a skin rash, you manage the skin rash. So whatever they have, you manage alongside. The patients are provided with a lot of information and treatment options, and the patients are very much involved in decision making, and the attendings will take the patient's decision and document it. Epic is a very extensive electronic medical record system. It was amazing at how much information has been collected about the patient from all the various hospitals they've been admitted in and past surgeries and all that. Very amazing. And from just one patient, you could learn a lot by just going through such records accordingly. Then also that the fellows are very few at Yale, maybe 3 or 4 per specialty. Unlike Uganda, where there are 10 or more at any one time, and the fewer the learners, the better for them because they get a one-to-one learning experience. And then in ICU, we saw that all diagnostics and treatments are provided for the patient irrespective of the cost, which is unlike in Uganda, where every diagnostic test or treatment, the cost plays a big role in terms of what the patient shall receive. So in conclusion, Uganda's journey in sleep medicine is still in its infancy, but we are optimistic with the ongoing collaborations and focused efforts. So by raising awareness, building capacity, leveraging of these international partnerships, including Yale, we hope to transform the landscape of sleep medicine and ILD in Uganda for the benefit of countless patients. So lastly, there is urgent need to improve pulmonary care, pulmonary training, and services in Uganda. Thank you very much for listening to us, and we invite questions or comments. Thank you.
Thank you so much to both of you for a fantastic talk. Yeah, I would love to open it up to any questions or comments from the audience. Please feel free to unmute yourself. I'll start off with one question that applies to both of you. But you both provided a long list of kind of lessons learned and comparisons and almost a wish list for things that you might be using to enhance care in Uganda when you return. Are there maybe 2 or 3 concrete things that you see as realizable on that list, maybe within the first 6 to 12 months upon returning, or are there things that you guys see as really priorities to tackle within both of your areas of interest?
So for ILD, the case conferencing where we discuss with the radiologists is very key, so that we are able to collectively look at the pattern of CT scan and agree on the diagnosis, is it likely ILD or not. That is a low-hanging fruit that we can do immediately. Also, we had been designing a pulmonary fellowship, but we did not include sleep medicine that time because we did not have access to information and knowledge. So we want to include sleep medicine in the training program of the postgraduates in Uganda. Over to you, Kimuli.
Yeah, so thank you very much, Lauren, for that question. And I think one of the key things here is the biggest hindrance is the lack of awareness of a problem with sleep in Uganda and in general in Africa. So indeed, in the next 6 to 12 months, it is very feasible to increase the awareness. In Uganda, we have a number of outlets that are helpful in disseminating information. But previously, it was difficult for anybody to come out and say something with authority when you don't have any training. And so people would look at you, so they know you were doing sleep medicine in Makerere, but especially the healthcare workers do not know where you got the training from. So now that you have the backing of the training and you have collaborations at Yale, the plan is to have excellent talks, scientific talks with healthcare workers, but also create an outlet for the general public through media and that's print and radio and television to at least alert them. During my stay here, I was able to liaise with the guys in Bank of Uganda because they got to learn about me having come here. And these are the people that are relatively can afford some of these devices, but would be happy to be taken away from whatever they are suffering from. These are the people that are wealthy. They are relatively obese. I'm not going to say that they are not obese because they have the money, and they would be happy to have some of these interventions given to them. So we've seen some of these advocates come through. Once they benefit from some of the services, they actually go and beat the drums even louder amongst other colleagues and even contribute to probably securing some of this equipment, since it looks like it's a savior for others that may be suffering. So I think generation of an awareness platform is going to be one of the most realizable. The others are probably going to come in through maybe riding on research projects. So maybe if there's a research project that is coming in pulmonary, we able to start writing grants and proposing that maybe we put in an aim of looking for what the burden of sleep apnea is in Uganda. Thank you. Oh, can you hear me? Sorry. Sorry, Lauren, could you hear us? Are we audible?
No, you were fine. I just forgot to unmute myself. Sorry.
Oh, sorry.
Okay.
You're fine. Thank you very much for your responses. I said, I'm sorry, I see another hand raised from Stuart Hoffman. Stuart, would you like to unmute yourself? Assuming that's an intentional hand raised. And there's a thank you in the chat from Dr. Yvonne Chu. Any other comments or questions? I see Laura Crawford on the line, and I just want to thank Laura in the office of the Yale Office of Global Health for supporting Ivan and Susan on this journey. Laura's amazing and has been doing this kind of work for a very long time and is total expert at making Yale and New Haven a warm and inviting place for people coming from all over the world. So thank you, Laura. And it looks like Stuart Hoffman was raising his hand unintentionally. Well, thank you all for coming. And I just want to echo what we said at the beginning, that Ivan, Susan, we hope this is not the end, but really just the start of a collaboration with all of you, and that you continue to consider this your Yale family, even after you guys return home to MUU pretty soon. And thank you everyone for hearing their stories this afternoon. Take care. We'll see you next week.